Okay, so today I'm going to be talking about CPT and HCPCS coding. Starting with CPT codes, which stands for Current Procedural Terminology, it is a standardized coding system used by physicians and other qualified healthcare professionals to report services and procedures provided. The purpose is to make sure that all insurance claims are processed in an organized and consistent manner. Its copyrights are owned by the American Medical Association, and the CPT editorial panel also includes the APTA to represent the physical therapy profession. In the year 2000, CPT codes became the national coding standard under HIPAA. The most commonly used CPT codes in the physical therapy profession is the 97000 series, which is the physical medicine and rehabilitation codes. Although some codes are used frequently by certain professions, it is not meant to be discipline or specialty specific. Going into a little bit about the history of CPT codes, the APTA started making changes in 92 when the term qualified healthcare provider didn't even exist and there was evidence of inappropriate billing by physical therapists. For example, the application of a hot or cold pack was equal to the value of 30 minutes of therapeutic exercise and therefore brought about a negative impact on the value of physical therapy services. In 94, there was a revision of the 97000 series, and there were significant improvements, such as there was about a 200% increase in payment for common services and a 230% increase in value of therapeutic exercise. The most commonly used codes in physical therapy are therapeutic exercise, gait training, manual therapy, neuromuscular re-education, and therapeutic activity. It's important to have proper knowledge of the definition of these codes in order to bill appropriately. For example, if you're providing gait training, there has to be cues or instructions regarding gait involved and not just distance walked. If you're billing for distance walked in order to address endurance, it is billed under therapeutic exercise. And then going into the new evaluation codes and re-evaluation codes that were implemented in 2017, the three new evaluation codes were tiered as low, moderate, and high complexity, which is based on the number of comorbidities and personal factors that the patient has. The new thing that did not change was that the CMS failed to adopt a tiered payment system for the new evaluation codes, but they did adjust the value for the re-evaluation codes. So you essentially got paid the same despite the level of complexity of your patient. The CMS is still collecting data on this to possibly make future changes to the payment system. Therefore, it is still important that clinicians have a good knowledge of these changes and bill appropriately. This is another example on how steps are taken from volume-based care to value-based care. I wanted to hit a little bit on the difference between timed and untimed codes too, because I feel that it is important to know the differences in order to bill appropriately. So timed codes require one-on-one time with the patient, and skilled therapy needs to be documented. It also includes constant attendance modalities such as ultrasound and iontophoresis, and examples of other time codes are therapeutic exercise, Theract, gait training, etc. What we must remember is that we get paid for what we do and not what the patient does. Untimed codes are also known as service-based codes, and it does not require one-on-one time with the patient. And you can only bill one unit of each service-based code per treatment session. And an example of these are initial evals, hot cold pack, and unattended e-stim. Next, I want to touch a little bit on HCPCS coding, which stands for Healthcare Common Procedure Coding System. It is defined as a standardized coding system used to identify products, supplies, and services which are not included in the CPT codes. And this includes durable medical equipment, prosthetics, orthotics, supplies, and ambulance services. It is an alphanumeric code, while the CPT codes are numerical. Commonly used HCPCS codes in physical therapy are the A, E, and L codes. The A codes are for medical supplies, so in regards to therapy, this can be exercise equipment. The E codes are for durable medical equipment such as walkers, canes, and crutches. The L codes are for orthotics and prosthetics, and Medicare defines orthotics and prosthetics as leg, arm, back, and neck braces, and artificial legs, arms, and eyes. So, why is coding so important to our profession? Well, it dictates how we get paid. Therefore, it is important to have a sound knowledge of it in order to bill appropriately and get reimbursed. Coming from the acute care setting for my first clinical rotation, CPT codes were used to measure productivity. In the position statement on value versus productivity measurement in acute care physical therapy, it talks about how the current time-based CPT codes do not apply to the acute care setting due to the patient's unique needs in the acute care setting such as comorbidities and complex diseases. Now, that is very different from the outpatient setting where these CPT codes are used frequently. For example, physical therapy services in the acute care setting also involves quite a bit of family or caregiver education and collaboration with other healthcare providers to determine the patient's plan of care. But these services do not have CPT codes associated with them. And if you focus solely on productivity, it can take away the value of services and turn the focus to the volume of services instead. So as a whole, it is important for us clinicians to stay current with the changes to codes and be proficient in your facility's EMR system in order to bill appropriately. This affects our profession as we continue to promote the value of the physical therapy profession in the healthcare system. As always, the amount of money involved in making changes to the coding systems can make or break decisions. For example, I read an article that talked about how falling 1% short of current payment rates would be an income loss to therapy of approximately $100 million a year. Therefore, well-informed clinicians can play an important role in this decision-making as we make the important change from volume-based care to value-based care.